To get extra, we have to do extra. Hello, dear friends. Myself, Dr. Shrikant Verma. Welcome to all of you at this INICET May 2025 Anatomy Recall questions. So, before starting the session, I want to inform you that this is totally recall based session. Questions, options, images may be different, but concept is same. Please suggest if any correction is there. Yes. So here is the one brief analysis regarding this INICET pattern. Total pure anatomy question, you can say 13. If you will integrate with other subject, definitely it will be cross so many number. Yes. Head and neck question, they ask the 3. Neuroanatomy questions 2. So you can say the neuroanatomy portion is covering the more syllabus, more marks for the INICET exam as well as NEET PG. And currently the same thing is followed in the FMG exams also. So you have to start the preparation according to the question pattern. Upper limb question 1, lower limb they ask the 2 question, then thorax, abdomen, pelvis, embryology, histology, all are 1 1 1 in number. So first we are going to start the head and neck question where the 3 MCQs had been asked. Let's start. So the first question you can see on the screen, what is the function of the muscle attached at mark point and they marked over the lateral pterygoid plate? Options were elevation, depression, retraction, and the rotation. Also, you can say side to side movement. So this is the muscle of mastication topic, which is commonly asked in our INICT. So it is not the new pattern. Yes, it is the favorite question of the first MBBS time also. So among the given option, the answer is the our depression. Why? Because this is the our lateral pterygoid plate which gives origin to the lateral pterygoid muscle from the lateral surface. So this is our lateral pterygoid muscle, and you can remember the action of the lateral pterygoid muscle with the formula DPS, Delhi Public School. Yes, D for depression, P for protraction, and S for side to side movement. So among this all, they given the depression option, so you can opt it. This is the favorite question of INICT. Very previously in 2016-17, they asked the similar kind of the question where they asked the controversy. They given the depression also and the protection also. So go with the Gray's Anatomy latest edition. According to the latest editions of the Gray's Anatomy, yes, the main depressor of the jaw, the geniohyoid, and our digastric muscle. So in such kind of a controversial pattern, you have to give the answer, sir, protraction. Okay. So if such kind of options are given, definitely you have to go for the depression. Few more points you can see in three-dimensional orientation, sir. This is our mandible, and here you can see the lateral pterygoid muscle. Can you see? This is our, yes, lateral pterygoid plate. Here is the medial pterygoid plate. The lateral surface of the lateral pterygoid plate is giving origin to the lateral pterygoid muscle, which is taking insertion into the pterygoid fovea. I taught you where muscle goes, there movement flows. This is the third Escavian magic. So when this muscle is contracting, it is pulling the mandible towards its direction, means forward. That is a protraction. Yes, along with the opposite side, lateral pterygoid as well as medial pterygoid, it will cause the, yes, you can say the side to side movement. And you can see it is having the two types of the fiber. One is upper fiber and another is the down fiber. So you can observe, if this muscle will contract according to its direction, it will cause little depression of the jaw also. But remember, the main depressor of the jaw is a geniohyoid and our digastric muscle. You will go with the depression. So here the few points for all of you which you can follow: the action of the lateral pterygoid, the DPS, depression, protraction, and side to side. Yes, sir. Remember the medial pterygoid, just instead of the D, you have to do EPS, the elevation, protraction, and side to side. So you can follow this image for the action of the other muscles. You can observe, sir, lateral pterygoid is responsible for the protraction. Sir, it is causing the depression, as well as along with the opposite side muscles. Yes, it will cause side to side movement. This is our temporalis. So temporalis oblique fiber, they will cause retraction. So remember, only retractor of the jaw. MCQ INICT question, answer is the temporalis. Yes, among the muscles of mastication, only depressor of the jaw, the lateral pterygoid. So these are the two very important points. Now look here, the temporalis will contract and it will cause elevation also. Sir, medial pterygoid, I told you the medial pterygoid action is our EPS, elevation, protraction, and side to side. In the similar way, the masseter, which is the strongest muscle of the body, it will cause elevation, closure of the jaw. And also you can observe the digastric muscle. Yes, it is having the entry belly and the posterior belly. So when this muscle will contract, it will pull down the mandible. So remember, main depressor of the jaw, answer is the our anterior belly of the digastric. Also, the genian tubercle to the hyoid, the muscle attached, that is a geniohyoid. So when it will contract, it will pull the mandible downside. So remember, main depressor of the jaw, the digastric muscle and the geniohyoid. But among the muscles of mastication, the only depressor of the jaw is the our lateral pterygoid, which I told you the formula, the DPS. And only retractor of the jaw, answer is the oblique fiber of the temporalis. Remaining all muscles are causing the elevation. So hope you got all the concept clear with this explanation, as well as this topic is very important for the INICT and NEET PG exams. Now come to the next question. This question is integrated with the ENT especially. You can see, while eating fish, a lady presented symptoms of the choking, hoarseness of the voice, and foreign body sensation in the throat. Okay, sir. On examination, fish bone was lodged in the piriform fossa. In our classes, I told you that it is smuggler fossa also, where smugglers are hiding the diamond. Yes, and at the floor of this smuggler fossa, piriform fossa, there is a location of the internal laryngeal nerve. So the answer is the internal laryngeal nerve. Try to understand the more concept. One quick revision, sir. You can see this is our larynx portion. Sir, the vagus nerve is coming. It is giving the branch to the larynx from the superior aspect. So this is our superior laryngeal nerve. Now this superior laryngeal nerve is dividing into two. One is going inside the larynx by piercing this thyroid and hyoid membrane, means thyroid membrane, and it is supplying the our laryngeal mucosa inside above the vocal cord. So this is what it is going inside. That's why it is internal laryngeal nerve. Another nerve is running outside and it is ending within the cricothyroid. I told you, जो नदी जहां रहती है, जहां बहती है, उस एरिया को सप्लाई करती है. So this cricothyroid muscle is supplied by which nerve? Answer is the external laryngeal nerve. Now try to catch this one. This vagus nerve is going down, but then it is giving one branch which is going opposite in direction. So this is recurrent in course. Yes, it is recurrent, and again it is supplying the larynx from the downside. So this is a recurrent laryngeal nerve. Remember, the left recurrent laryngeal nerve is hooking the arch of aorta, better to say the ductus arteriosus ligamentum arteriosum, which is the remnant of the left sixth pharyngeal arch artery. While on the right side, this right recurrent laryngeal nerve is hooking the our, yes, left sixth pharyngeal arch artery, right sixth pharyngeal arch artery, better to say right sixth arch, because it is on the right side. But remember, this right distal part of sixth pharyngeal arch artery, it disappear, and fifth arch artery also disappear. So this fourth arch artery, which is making the subclavian artery, it is persisting. So on the right side, this recurrent laryngeal nerve is hooking the our, yes, right subclavian artery. Now it is supplying, both are supplying the our larynx below the vocal cord. So all the laryngeal muscles are supplied by the recurrent laryngeal nerve except cricothyroid, which is supplied by the external laryngeal nerve. In our detailed classes, we had seen just one quick revision. And above the vocal cord, the sensory nerve supply is the internal laryngeal nerve, and below the vocal cord, sir, the sensory nerve supply is the recurrent laryngeal nerve. Okay, sir. Now, after this all, you all are having the clear concept. This internal laryngeal nerve will go deep to the mucosa and it will lie just at the floor of the piriform fossa, smuggler fossa. So in this question, the answer is the our internal laryngeal nerve. Also, you can say internal branch of the superior laryngeal nerve. Now come to the next question. Always we are looking the face topic. Yes, the face, the facial muscle, the facial nerve, the trigeminal nerve, they are always important topic. And before starting the session, I always tell this one, that one question sure from the face, facial nerve, trigeminal nerve. Again, they ask the same kind of the question. Which muscle is primarily corrected in the cleft lip surgery? So they are asking the ENT surgery, cleft lip surgery, but answer is the anatomy. Can you see the levator labii superioris? Yes, orbicus oris, orbicus oculi, masseter. Sir, you can exclude. Masseter is the muscle of mastication. You can remove. Orbicus oculi, sir, it is the muscle around the our orbit. How it can be the answer? Levator labii superioris. Sir, this muscle is coming from the our, yes, below the orbit part and getting inserted into the our upper lip. So it is the sad muscle. Okay, it is not getting damaged. But orbiculus oris, yes, during the class I taught you the orbiculus oris is, yes, orbital shape muscle around the our oral opening. So in case of the cleft lip, there is the problem in this orbiculus oris muscle. So remember this one, sir, there is the problem, there is the cleft lip. So this orbiculus oris muscle is getting damaged. Yes, there is a problem in this orbiculus oris muscle, three-dimensional orientation. So first you have to suture this particular muscle. Definitely, without any kind of the doubt, answer is the orbiculus oris. Now come to the next question, neuroanatomy. So here the question, olfaction is carried by all except. So this is the one tricky question. We know very well olfaction is carried by only the first cranial nerve. So you can say, sir, all these answers are wrong. All these answers are wrong. But just try to understand few authorities. You will see the literature. You will see the many kind of the articles. They will say the olfactory pathway and the taste pathway both are running parallel together. Okay, sir. Definitely the olfaction is carried by the first cranial nerve. But they are asking all except, and yes, all are, we are not aware. So I'm just giving the updated knowledge for all of you. Sir, taste pathway, you all know, sir, there is a tongue, sir, anterior two third, and there's a posterior one third, and the posterior most part. Okay, so anterior two third, there is our chorda tympani. So this is the branch of the facial nerve. Posterior one third part, sir, that is a branch of the, yes, it is since the taste sensation is carried by the glossopharyngeal nerve, and the posterior most part, the taste sensation is carried by the vagus nerve. Okay, so these taste pathway, yes, they are also contributing in the our olfactory pathway little bit according to the recent update and the articles. Yes, so you can say, sir, glossopharyngeal nerve and our vagus nerve, they will participate. Also remember, trigeminal nerve, it is giving the branch lingual nerve. Yes, it is carrying the general sensation. So in case of the irritation of the tongue, in case of the irritation of the tongue, this trigeminal nerve is also getting stimulated. It is also having the little bit contribution in the olfactory pathway. Okay, so now observe the 12th nerve, hypoglossal nerve. Sir, this is pure motor nerve. No sensory kind of the activity is there. All other are having the sensory activity also, but hypoglossal nerve is purely motor. Okay, so according to this our controversial question pattern, okay, you can opt the hypoglossal nerve. So here is a little description for all of you. Sir, 12th nerve is pure motor, rest all other are mixed nerve. Taste pathway also participate in the olfactory sensation. Yes, the facial ninth and trigeminal nerve also play supporting role in the smell distinct from the primary olfactory nerve. These are the things from the article and the updates. While the olfactory nerve handles the sensation of smell and trigeminal nerve defects, irritants, temperature and pressure in the nasal cavity contributing to the all over odor preparation. So definitely this is the controversial question. Olfaction is carried by only by the olfactory nerve, and you can say none is the answer, but you have to opt one single best answer. So during the class I told you, who is wife of Salmon Boy? None is the answer. In that situation, what you have to opt, how you have to catch the point? Yes, it is the similar kind of the question. So among the given option, definitely the answer is the our hypoglossal nerve. One thing you have to remember, it is pure motor nerve. Now come to the next question. In this question, they are asking about the pain from the marked structure can be referred to which of the following. So here in this image, you can observe this is our foramina magna, and this is the our torcula hierophili, where the different sinuses are meeting. Do you remember the hierophilus, the father of anatomy? I told you. So here you can see the position for the superior sagittal sinus, occipital sinus. Yes, there is the our transverse sinus, and straight sinus is also coming. So this is the torcula hierophili. So definitely here the cerebral hemisphere, the occipital lobe is lying, and here the cerebellum is lying in the cerebellar fossa. Okay, sir. So this is the posterior cranial fossa. So they are asking about the posterior cranial fossa sensory nerve supply. The pain from the marked structure can be referred to which of the following. So definitely this is the area which is not related with the ear. You can exclude it. Vertex, sir, vertex is for shoulder. How the shoulder can be the answer? But the back of the neck, the foramina magna, yes, it will continue just foramina magna, yes, the medulla oblongata is here, which is continuing as the spinal cord. So it is going to the our back of the neck. So you can use the common sense also. The answer is the back of the neck. But this question is related with the nerve supply of the meninges. So one information for all of you. This is again the information from the our different kind of the sources from the updates. So we are looking that there is three kind of the nerve supply: anterocranial fossa, then middle cranial fossa, and the posterior cranial fossa. So according to this, yes, you can observe the anterocranial fossa is supplied by the, yes, trigeminal nerve, ophthalmic division, sensory nerve, and the maxillary nerve. While the middle cranial fossa is supplied by the V1, V2, and the V3. Posterior cranial fossa, sir, it is supplied by the, yes, meninges are there. So these are supplied by the vagus nerve and the glossopharyngeal nerve, as well as spinal nerves C1, C2, C3. Their dorsal rami they are supplying. One simple diagnostic presentation for all of you. Just observe here. Suppose this is the our cranial cavity, right, sir? Suppose this is the Turkish shuttle, Sela Turcica, and this is indicating the landmark for the entry and the posterior cranial fossa. Sir, this is the anterocranial fossa. Suppose this is the our middle cranial fossa, and here is the our posterior cranial fossa. Yes, this largest foramen of the skull is indicating the foramina magna. So this anterocranial fossa, it is supplied by, do you remember, sir? Here is the our superior orbital fissure. Yes, sir. And from the superior orbital fissure, the V1 and V2 they are passing. अगेन द फॉर्मूला इज हिट, यस, जो नर्व जहां रहती है, जहां बहती है, उस एरिया को सप्लाई करती है. विच नर्व इज हियर, सर? Our ophthalmic division of the trigeminal nerve, which is sensory. Also, the few branches of the V2 maxillary nerve they are supplying. Sir, the middle cranial fossa, it is supplied by the V1, V2, as well as mandibular nerve, V3 nerve. But the posterior cranial fossa, according to the our, yes, different authorities, you can observe the nerve which is supplying, that is the our vagus nerve branches as well as the glossopharyngeal nerve. Yes, also the cervical nerve C1, C2, and C3. Their sensory branches are supplying. So these are the nerve supply of the posterior cranial fossa. Just diagrammatic presentation, glossopharyngeal nerve and vagus nerve. The meningeal branches you can say, and the C1, the C2, and the C3 you can say. Okay, so according to it, the answer is the back of the neck. Here we described all the aspect. In INICET May 2025, the two questions from the neuroanatomy, three questions from the head neck face, and one question from the upper limb. Always during the session I told you, in upper limb the most important topic is the nerves. Okay, so this time again they ask the same thing: which of the following muscles are supplied by deep branch of the ulnar nerve? Options are third lumbrical, fourth dorsal interosseous, opponents digitiminimi, and flexor carpi ulnaris. During the class I told you the course of the ulnar nerve, it's all the clinical aspect with integration to the other subjects as well as the branches. So in the forearm, the ulnar nerve, the superficial branch is supplying the flexor carpi ulnaris. Okay, sir. And remaining all are supplied by the deep branch in the hand. So answer is the 1, 2, 3. Answer is the 1, 2, 3. So according to it, the correct answer is the A. Just one quick revision, sir. Ulnar nerve, it is having the root value C2, C8, and T1, but according to the Gray's anatomy, C7 is also participating. Now it is running in the axilla, no branches. In the arm, yes, only one branch it is giving to the elbow joint, and then it is mainly running in the forearm and the main nerve of the hand. That's why it is known as the musician nerve, because it is the main nerve of the hand and it is supplying the short intrinsic muscles of the hand. So you can see here, sir, in our forearm it is supplying only the 1.5 muscle, the flexor carpi ulnaris, MCQ, and the medial half of the flexor digitum profundus, MCQ. Yes, its lateral half is supplied by anterior interosseous nerve. That's why it is also known as hybrid muscle, right, sir? Now this nerve is passing and it is giving the cutaneous branches. It is giving the palmar cutaneous branch, which is supplying the, yes, medial one and a half of the finger in our palmar side. Again, I want to inform you, dermatome, they are overlapping in nature. So in different textbook, you will see difference. Okay, different context, different person, different author. Yes, there are the variation because dermatome, they are overlapping in nature. It is giving the dorsal cutaneous branch, which is also supplying on the dorsum. Yes, you can say the medial 2.5. Few author will say, sir, medial 1.5 on the dorsum. Now you can see the cutaneous branch is also giving the branch to the our remnant of the panniculus carnosus. When we hold any object, there is the roughness over the hypothenar eminence. So this roughness is produced by our palmaris brevis. Okay, sir. Now look further. It is giving the deep branch, and these deep branches are supplying all the 15 muscles in the hand. Yes, one muscle, try to understand, one muscle, that is the palmaris brevis. So the remaining 14 muscles of the hand, they are supplied by the deep branch. The only five muscles are supplied by median nerve. What are the five muscles? Yes, all the muscles of the thenar eminence. Yes, abductor, pollicis, brevis, flexor, pollicis, brevis, opponens, pollicis, except adductor pollicis, which is the graveyard of the ulnar nerve. So remove it. And then first and second lumbrical. So total five muscles are supplied by the median nerve. Rest all are supplied by the ulnar nerve. Yes, superficial branch is supplying only one muscle. That is our palmaris brevis. Yes, it is again the cutaneous branch for the dermatome. Yes, it is supplying the all the four hypothenar muscle. Okay, abductor digiti minimi, flexor digiti minimi, opponents digiti minimi, and you can say the palmaris brevis, but sir, it is supplied by the our, yes, you can say superficial, it is supplying the our, yes, it is the remaining all are supplied with the deep branches. Now you can see it is supplying to the graveyard of the ulnar nerve, that is the electropolysis. It is supplying third and fourth lumbrical. Remember, the first and second lumbrical supplied by the our median nerve, and then it is supplying all the palmar and all the dorsal interossei. So in this way they kept this flexor carpi ulnaris. Sir, it is not supplied by the deep branch. Remaining all are supplied by our deep branches. So according to it, correct answer in this question is A. Now come to the next question. Now we are moving for the lower limb part where the two MCQs had been asked. Look here, the first question. Yes, when this question asks, can you recall our statement from the class? One question sure short from the gluteal region in INICET especially. Also, these are repeated in the NEET PG as well as you can see the FMG exams. So they are asking the gluteal region question. What is the action of the muscle marked with arrow in image? So here they are marking. Yes, this is the site for the attachment of the gluteus maximus. So again, I am going to show you the three-dimensional orientation so you can recall our class discussion. So catch this point at our gluteal region. The three big gluteal muscles are there. Can you see this is the gluteus maximus? Yes, sir. It is having the origin from the sacrum. Yes, exactly at this part in the INICET they given the arrow. Also you can see they are taking origin from the our iliac crest. Lots of the words are there, but now in recent pattern you have to just remember the important point. So it is taking origin from the our posterior gluteal line, area behind the posterior gluteal line, from the our iliac crest, the outer lip, the posterior one third of the iliac crest, also the adjacent surface of the sacrum, adjacent surface of the coccyx. Yes, also there is our ligament. Yes, between the ischial tuberosity and the sacrum, that is the our sacrotuberous ligament. So from here it is taking origin and it is getting insertion into the our gluteal tuberosity of the femur. Only one fourth part, the three-fourth part is getting inserted into the our iliotibial tract. So now can you see the direction where muscle goes, their movement flows, because it is crossing the hip joint from the back side, so it will cause back movement, means it is the chief extensor. During the class I told you that it is helping us from sitting to the standing position. So in case of the Duchenne muscular dystrophy, this muscle is affected. That's why patient is not able to stand from the sitting position. So there is the Gover's sign positive, that is the medicine and the pediatrics integration. But among the given option, they not put the extension at the hip. Few students are saying, sir, extension of the hip was there. If extension of the hip is there, definitely it is the best answer. But if it is not present, then can you see the upper fiber, they are coming from the upside and inserted into the femur. So when they will contact, where muscle goes, their movement flows. So can you apply? Yes, the our third Escavian magic, when it will contact, it will cause lateral rotation of the femur. It will cause lateral rotation femur. So it is external rotator. Also, yes, when it will contact the upper fiber, they will help in abduction. So abduction at the hip also. So they are helping here. Definitely the best answer is the extension at the hip. But if it is not given, then you can go with the external rotation of the hip. You can go with the external rotation of the hip. So answer in this question is our extension, external rotator. Yes, the other points just in a quick view I given you. You can get the slides from my Insta profile. Don't forget to follow me at Insta and the YouTube, Dr. Shrikant Verma classes. Now come to the our next question. Yes, lower limb. They are asking one more question. Which muscles are supplied by superficial peroneal nerve? I told you in the leg there are the three compartments: entry compartment, lateral compartment, posterior compartment. Sir, there is no medial compartment. except at the upper part where the sartorius, gracilis, semitendinosus, and tibial collateral ligaments are attached, which you can remember with the funny mnemonic Salmon गधे से टकराया. S for sartorius, G for gracilis, S for semitendinosus, and this is tibial collateral ligament. So no other muscles are attached at the medial side. So this is the entry compartment. The nerve of the entry compartment, I taught you the deep peroneal nerve. So the deep peroneal nerve will supply all the muscles of the entry compartment. Means it will supply to the tibialis anterior, it will supply to the extensor digitorum longus, it will supply to the extensor hallucis longus, it will supply to the peroneus tertius. Remember, few authorities, few places you will see it is hybrid muscle. Sir, Gray's Anatomy, the 42nd edition, the page number 1418, it is clear cut saying the fibularis tertius, also you can say the peroneus tertius. Yes, it is having only one nerve supply. It is supplied by the nerve of the entry compartment, the deep peroneal nerve. Our Hilton law, our second Escavian magic is clear cut, easy at this part also. So you can observe, sir, this peroneus tertius is also supplied by the deep peroneal nerve. It is not supplied by the superficial peroneal nerve. Now you can see the lateral compartment. In the lateral compartment, sir, this is the peroneus longus. Sir, this is the peroneus brevis. So in the lateral compartment, SPN, this is sapana, superficial peroneal nerve, which they ask in the exam. So it is supplying only the peroneus longus and the peroneus brevis. It is not supplying the peroneus tertius or extensor hallucis longus. These are supplied by the our deep peroneal nerve. So definitely the answer is the first and second. The nerve of the posterior compartment, sir, answer is the tibial nerve. So all the muscles on the posterior compartment, the GSP, gossip, the gastrocnemius, the soleus, the plantaris, even the popliteus, these all are supplied by the our tibial nerve. Tibial nerve is the nerve of the posterior compartment. Also you can see, sir, just behind the medial malleus, the NEET PG 2024 question, tibialis posterior, it is supplied by the tibial nerve. Sir, flexor digitorum longus supplied by the tibial nerve, and the flexor hallucis longus, tibial nerve. So all muscles on the posterior compartment, they are supplied with the our tibial nerve. Again, entry compartment, deep peroneal nerve, lateral compartment, superficial peroneal nerve, and the posterior compartment supplied by the deep peroneal nerve. Now we are going to see the one question from the thorax topic. So nowadays in our INICT, also the NEET PG as well as in FMG, yes, they are giving the CT chest, CT abdomen, and also you can compare this topic with the our transverse section of the thorax and the transverse section of the abdomen. Okay, we discussed very nicely during our regular classes. Again, you can observe here question the cross section of the thorax with four labels A, B, C, D, and match the following. So can you observe here, sir, one by one, step by step? Can you catch the point, sir? This is anterior, sir. Here is posterior. How, sir? This is the vertebra, and you can see the spinal cord also, right, sir? So you can observe there is the our position of the lung within the thoracic cavity. So this is the right lung, and here is our left lung. You can easily see, sir, this is our heart, right? Now during the class, yes, I told you, yes, this is the entry side, so definitely it is the sternum. During the class I told you, yes, the anterior surface of the heart mainly formed by the right ventricle. So this is the right ventricle. Sir, apex of the heart, which is towards the left side. So definitely it is our left side. Yes, it is formed by the left ventricle. Another clue you can see, sir, the wall of the left ventricle is very thick. So this is our apex of the heart, which is formed by the left ventricle. Right, sir, it is the left ventricle. Also, you can observe from the our left ventricle, the aorta is arising. So this particular point, third is nothing. This is the our aorta. Also you can say the aortic valve at the site of the origin. Okay, sir. Now you can observe the right border of the heart. The right border of the heart is only formed by the right atria. Sir, this is our right atria. Now just in front of the our vertebra, can you observe, sir, this particular cavity in front of the vertebra? This collapse structure is our esophagus, right, sir? Now in front here you can see one more cavity which is within the our pericardium. So this is a pericardial sac. Okay, sir. Yes, during the regular class I told you just in front of the esophagus, whatever the chamber is present, sir, this is our left atria. And I told you the base of the heart, two-third formed by the left atria and one-third formed by the right atria. Okay, sir. You also observe this is aorta, so it will go upside, backside and left side, and it will descend. So this is nothing, this is our descending thoracic aorta. Okay, sir. So now you can observe one by one, sir. This first is nothing, it is right ventricle. This second is nothing, it is the left ventricle. The fourth is our point of the right atria, and third is our aortic wall, also you can say aorta. Now look for the option. Yes, what is the correct matching? So first point, they are asking about the first point, means it is the right ventricle undergoes hypertrophy on pulmonary stenosis, right, sir? Whenever you know also the tetralogy of the fallot very nicely. In the tetralogy of the fallot, there is the overriding of the aorta, yes, which causes the narrowing of the pulmonary wall, that is a pulmonary stenosis. Yes, due to the pulmonary stenosis, there is our right ventricular hypertrophy because it is connected with the right ventricle. So you can apply this law, right, sir? This is our first is our right ventricle. Yes, you can say. Now this our next, due to the right ventricular hypertrophy, there is a pressure is more in the right part of the heart. So there is our right to left shunt through the our ventricle septal defect, VHD. So you can correlate with our pediatrics and the medicine also. Now come to the next. The second receives oxygenated blood. Second, the left ventricle, it is receiving the oxygenated blood. Sir, it is the left ventricle. Yes, it is receiving the oxygenated blood from the our left atria, which is receiving the blood, oxygenated blood from the lungs. That is also right. Okay, sir. Now look, the third, yes, arises from the left ventricle. So third point is our aorta, which is arising from the our left ventricle. Yes, it is true point. You can see easily the third point, the aorta is arising from the our, yes, you can say the left ventricle. Now the fourth point, can you see, lies to the right of the ascending aorta. So the fourth point, you can observe it is our right atria, and here is our aorta. Yes, it is on the right side of the, this fourth point is the right atria, which is on the right side of the aorta. Okay, sir. So these are the statement. Now they are giving options within the option. So that's why the INICET practice is a little different. You can see the first, undergoing the hypertrophy of the pulmonary stenosis. Yes, we had seen. Second, receives oxygenated blood. Right. The second portion was our left ventricle, which is receiving the oxygenated blood. Yes, it is also right statement. Now third, the aortic wall, the third was the our aorta, the third was our aortic wall, so it arises from the left ventricle. It is also true. Next, last, the fourth point, which is the our right atria, it lies, yes, right of the ascending aorta. Yes, sir, it is also right statement. So you can see, you can compare, be cool, calm, relax according to the given option. Other options you can match, they are wrong. So A is our correct answer. Okay, so get ready for this transfer section of the thorax and transfer section of the abdomen, and it will be useful in the identification of the CT chest and CT abdomen also. Now come to the next question. Now we are going to see the two MCQs of the abdomen part. Yes, you can observe here the question, which of the following is not a boundary of the hepatocystic triangle? So this is the integration with the surgery. Yes, options are common hepatic duct, inferior border of the liver, cystic duct, and the cystic artery. So the cystic artery is not participating in the hepatocystic triangle. Also, you can say hepatobiliary triangle. So the cystic artery is participating in the Carot's triangle. So here is a short, sweet discussion for all of you. Can you see? Sir, this is the, our liver, right? Sir, this is our common bile duct, which is giving the cystic duct. This is the common hepatic duct, yes, which is dividing into the right hepatic duct, and here is the our left hepatic duct. Sir, this is our gallbladder, and this is our inferior border of the liver. So the hepatobiliary triangle, sir, hepato means liver, biliary means gallbladder, biliary tree. So there is one triangular formation between the biliary apparatus and the liver. This is the hepatobiliary triangle. Also, you can say hepatocystic triangle. What are the boundaries? Sir, the base, or you can say superior border, it is formed by the inferior sharp border of the liver. Okay, sir. Right side is formed by the cystic duct, right, sir? And the left border is formed by the common hepatic duct. Correct. So the cystic artery is the content, but the cystic artery is not participating in the boundary. Yes, according to the Gray's Anatomy and the surgery books, the Callo's triangle is different. Can you see? This is the our Callo's triangle. What are the boundaries of the Callo's triangle? Sir, all are CCC. This is the mnemonic C for Callo's triangle. All are CCC. Yes, the right border is formed by the cystic duct. Sir, the left border is formed by the our common hepatic duct. Now the base is formed by the our cystic artery. Okay, so all are CCC, cystic duct, common hepatic duct, and the our cystic artery. And here the content is the cystic lymph node of the Lund. Okay, so sometimes this lymph node is getting enlarged and it is causing the obstructive jaundice. So this is the clinical point. So hope now you are having the clear concept about the Carrot's triangle as well as the our hepatobiliary triangle. You can go for our regular classes also. Now come to the next question. Here in the next question, yes, they are again giving the cadaveric image. I told you during the classes that one question from the prostate, sure, yes, the rupture of the bulbar urethra, sure. This time they ask the question to identify the cadaveric image, the prostate region, the porous surface of the bladder. Match the following. So look here, sir, this is our appearance of the urinary bladder porous surface. So you can easily observe, sir, this large structure is nothing, it is our urinary bladder. Sir, urinary bladder is having the our opening of the ureter. So you can see, sir, ureters are coming. So this A is nothing, A is our ureter. Now also you can see the ureter is having the close relation with the our, yes, the ductus difference, was difference also you can say. And now this was difference is meeting with the seminal vesicle. Can you see this glandular appearing structure? So this C is nothing, it is seminal vesicle. Yes, now both will unite together and they will make the ejaculatory duct which will open within the prostatic urethra. Okay, so definitely this D is nothing, it is located at the neck of the bladder. So this is definitely our prostate gland. Okay, so they ask the cadaveric image during the regular class. Yes, we had seen such kind of the image, the urinary bladder. Sir, there is our ductus deferens. Sir, there is our seminal vesicle, and both are combining in together and making the ejaculator duct. And there is a location of the prostate gland at the base of the bladder, at the neck of the bladder. Okay, sir. So according to it, you can match. A is ureter, B is was difference or ductus difference, you can say. C is seminal vesicle and D is prostate. So according to given option, answer C is correct. Now come to the next question. Always I say one question from the histology, one question from the embryology. It is usual pattern, but sometimes they give the so many question and we have to look for the histology and the embryology. Why? Because if you will know proper histology, your pathology will be strong, and if you will go for the our embryology, your pediatrics and medicine and the obs-gynae other subject will be stronger. Okay, so for the proper concept, go you can go for the our regular classes and the videos where I given the excellent concept of the histology as well as embryology. So here we are going to look for the MCQ. So just look here the question. Identify the marked structure. So they are giving the option respiratory bronchus, terminal bronchiole, and the alveoli. Can you see this image? Yes, this is not the new image. This image already asked in our previous INICET pattern. Okay, so look here. You can observe this is our duct, and the wall of the duct is getting thin slowly. Okay, and now it is showing the pouches which is going inside. Definitely according to the options, sir, this is our respiratory pathway, and these cavities are nothing, these are our, yes, you can say, alveoli. Okay, now we know very well, sir, in our respiratory pathway there is a trachea, then primary bronchus, then secondary bronchus, then tertiary bronchus. Tertiary bronchus is supplying to the bronchopolyp segment, then it is dividing to terminal bronchiole and then respiratory bronchiole. The respiratory bronchiole is the part from where the gases exchange starts. So the respiratory bronchiole, they are very thin. So remember, this thin walled layer is our respiratory bronchiole, but this thick layer is showing our terminal bronchiole. Okay, sir. So this is the our point. You can easily observe. Here is the image. You can observe, sir. This is the our terminal bronchiole, and here you can see the respiratory bronchiole. And sir, these are the our alveolar sac, and the duct which is opening into the alveolar sac, that is our alveolar duct. Getting the point, everybody? Okay. Yes, you can observe the alveoli also. So definitely they marking. They if they are marking over this area, at this area, answer is the terminal bronchiole. If they are marking the thin area where you can see the small pouches, where you are able to see the small pouches, this is our respiratory unit where the gases exchange starts. So this is our respiratory bronchial part. So Previously, they asked in the INICT the respiratory bronchus. This time they ask the question over the terminal bronchiole. Now come to the next, our question over the histology. Here, I want to do one correction that they asked the two question from the histology and no question from the embryology. So what was the other second question in INICT May 2025? Sir, how does the marked cluster of the cells affect nearby cell? So they are giving the image, histology image. Yes, this question had been asked earlier in our NEET PG exam. This is nothing. This is our pancreas. You can see the dark eosinophilic area all around, where you can see the serous acini gland, secretory glands. Okay, sir. But here, the little less pigmented area, less eosinophilic area, it is nothing. It is the our islet of the Langhans. Okay, sir. This is the our islet of Langhans. Okay, so definitely they are asking about the pancreas. So this is the question of the anatomy histology. But when you will read the question, then you will see they are asking about the function, means physiology. So this is the anatomy physiology integrated question. If you know only the anatomy, you cannot give the answer. If you know only and only the physiology, you cannot give the answer. You have to know the both. Yes, they are giving the option, the portal vasculature, the paracrine effect, the transformation from epithelium to mesothelium, and nerve mediated. So they are asking the mechanism of action of the islet of the Langhans, or you can say the beta and the alpha cells, how they are acting. I told you during the regular class. Nowadays they are asking about the gland. Sure, they are asking the ecrine gland, they are asking the apocrine gland, they are asking the holocrine gland. Yes, now they are asking the paracrine gland. So try to understand, sir. Paracrine signaling, the physiology part, this is the type of the cell communication where a cell releases a signal molecule that affects nearby cells. Always I say to the student, everything is hidden in the name. See, paracrine, para means surrounding. So there is the any cell. Suppose this is our beta cells, this is our alpha cell. So beta cell is secreting the our insulin, and alpha cell is secreting the glucagon. So what is happening? The secretion, they will affect the nearby cell. So this is our paracrine effect. Sometimes you will see the secretion, they are stimulating the self or inhibiting the self. So this is the autocrine. Okay, so they are asking about the paracrine activity. So answer in this question was the paracrine. So this was the our histology question. So again, if any doubt or any query, you can stay tuned with my all the social media channel. Thank you. If any correction you need, any word, any kind of the option, any question, please inform me. Again, I want to tell you that it is a recall based session. I tried my best. Concept is same. Maybe the images, the wording, yes, the option little bit they may differ, but the concept will be same. Okay. So always the overall analysis, if you want to do, you will see, sir, they are asking the head, neck, and the neuroanatomy question more, and other zones just single. And also stay tuned. If you will do integration, then more and more question, more than 50, more than 100 topics you can integrate with the anatomy. So we will meet together in our regular classes. All the best. God bless you all.